you very much, and thank you very much to all of you for sticking it to the bitter end. Together with Catherine and Beverly Parkin for Royal Academy of Engineering, we organised this conference today on behalf of the Royal Academy of Engineering Biomedical Engineering panel, which I chair, and so it was my prerogative to go in for the graveyard slot. But thank you very much to all of you who've stayed this long. I think the quality of the presentation has been excellent. Geoff, you've been an excellent chairman, so I thought I would get that in before I try to bring you to a close in the next 20-25 minutes. Now, one thing Mirella did say is that nobody's defined innovation, and yet I'm the last presentation. The advantage of being the last presentation having a laptop is that actually I give a lecture to the first-year engineers, and one of the topics we talk about is innovation. So I've inserted 2 extra slides very quickly to try and define what is innovation. This is really nice and simple, easy. Remember, this is a lecture to the first-year undergraduates. I use a report, joint report between the Engineering Council and the Royal Academy of Engineering, of course, called the Universe of Engineering, a UK Perspective, which came out in 2005, and it attempts to define innovation. Engineers, we're very pragmatic, so it's actually a very simple definition. Innovation is the successful introduction of something new. I think that's as good as any. It certainly works when we go through it in undergraduate lectures, and it's one that you can remember easily. Now, in the report, it goes on a little bit more to define that in the context of the economy, in the context of society. Of course, in the context of healthcare, both applies, because, of course, we would like our innovation to bring commercial success, and, of course, a lot of healthcare innovation is about improvements in the quality of life. But going to my main topic, having finished with the 2 extra slides, I thought since I was speaking in London, and we're nearly in 2012, that I would describe the innovation ecosystem like this. And it worked really well, actually, when I thought of this, because we've had academics. We had Roger from Bath this morning kicking us off. We had Jim Easton from Department of Health. We've had the MHRA and Mirella from NICE as regulators. By the way, the colours, I did think about them a little bit, but not too much. So the fact the Department of Health is in black, don't read anything into it. Industry, we approaches Biomedical and so on in yellow, and I've been nice to healthcare professionals because we can't really do anything as engineers, in biomedical engineers, without healthcare professionals, so I've given a nice green ring. But of course, as I hinted earlier, the patient is missing, and the patient should really be right to the center of that. And I think from both the research I've been involved in and the clinical trials I've been involved in the last 8 or 9 years, and other research I've done from looking at what's happening outside of the UK, that the informed patient is going to be part, either active, passive, or somewhere in between of the innovation ecosystem. I really believe that we are witnessing a trend which is accelerating. So what is the informed patient? Well, it's actually quite interesting when you go to the Department of Health's website and you look at NHS Choices, which is enabling people to log on and decide what treatment might be best to them, etc. 10% increase last year compared to 2009, but staggeringly, 100 million people have actually logged on to this. Now, Imperial College, lots of them represented here, did a study for the Department of Health and found that 70% of patients use the internet to look at health information, with as many as a third deciding not to go and bother their GP. So quite interesting, improving the efficiency of healthcare delivery because they actually found what they wanted on the internet. Now, I personally think that 70% is a slight overestimate. A big US survey looked at the same thing recently, and the figure there was 52%. But we can safely say that half the population actually nowadays goes onto the internet to retrieve healthcare information. And I believe, as I've already said, that this trend will accelerate with the use of social media, mobile phones. And although I'm going to be talking about mobile phones, we can almost say now, instead of mobile phones, smartphones, because 1 person in 3 in this country has a smartphone now, for 90% of people having phones. And when you look at social media, I did a bit of research in preparing for this talk, and one of the sites that I came to was Cure Together. And it's a social networking site. Patients can list their symptoms, the treatments they've tried, the results they've got, and share that. As I say, one of the big, still mystery illnesses is fibromyalgia, and I do know one or two people who got fibromyalgia, and there are definitely some recommendations that some patients have made about some use of drugs that they've made or other medical devices for pain relief in fibromyalgia. And that has come from the patients sharing information together. And one of the things that the Cure Together site does is try to organize this in some ways to come to firm conclusions through some research projects where the patients are active partners. But perhaps the best known of these, and there are others, is Patients Like Me. Patients Like Me, extraordinarily very similar to Cure Together in some ways. Members share condition, treatment, symptom information, etc. It has 110,000 members now, all over the world. It started with somebody whose brother developed ALS, which is a very tough neurodegenerative disease whereby median length of survival after first symptoms is between 3 and 5 years. And he created a community of thousands of ALS patients, up to about 5,000 now, and it has now expanded to 110,000. And members can remain anonymous if they want, but interestingly, most of them do not. So, for example, a typical page, someone who has epilepsy, here, there are 2,354 patients with epilepsy in Patients Like Me, and this is the information that Sarah, a female of 36 years old, is happy to share about the treatment that she's following, the symptoms, even when she has seizures, her weight, etc. And comment on the issues that are most important to the patients. So I think it is very interesting that we are really seeing healthcare applications of social media. It is free. It's a free online community. As I say, patients are encouraged to be completely open, to give their names and so on. They support each other at various stages of their illnesses and so on. And the way that Patients Like Me actually makes money and is a business, and they're very upfront about this, is that they sell the anonymized data or de-identified data to pharmaceutical companies. And one of the most interesting things, we've talked about clinical trials, and I'm trying to encourage my clinical colleagues in Oxford to think about this for our next COPD trial, is that there was a paper in Proceedings of the National Academy of Sciences in USPNAS about a small sample study of the order of about 40, 50 patients in terms of the use of lithium carbonate to slow down the progression of ALS. And what they did is, as they realized that some of their patients, having found this paper, started taking the drug, they actually organized a clinical trial which involved hundreds of patients. Now, I don't have time because I want to keep to my 20 minutes to take you through this. The interesting thing is it was published in a perfectly reputable journal. It's in Nature Biotechnology in May of this year. And they did something quite clever in terms of matching controls with the intervention group, looking at the trajectory of the progression of the disease before starting to take lithium. So this is functional rating scaling, which all patients did, and you can see the red and blues are pretty well matched by the time you get to the start of the trial. So it's not a randomized controlled trial, but the way their matching algorithm has been devised, it's pretty good. And this is all self-organized, and they were able to have 149 patients taking lithium and 450 or so not taking lithium. Unfortunately, the conclusion was negative, but an important conclusion because it involved 600 patients. It revealed that the drug had no effect on the progression of the disease, contrary to the small Italian study. And of course, far more powerful because it had more than 10 times the size of the original study group. And it allows you to do a trial with some of the benefits of a randomized controlled trial in terms of having control and intervention group and trying to match them as best you can without some of the difficulties of running a large RCT. So that was social media. Let me cover for the next 10 minutes apps, mobile phone, cell phone, smartphone applications. You probably remember this key day in the history of smartphones for healthcare, August 22nd, just a few months back, when our Secretary of State launched a call for ideas for new health apps and maps, which went on the website. We did submit 3 apps. We did not realize, which was slightly to our detriment, that actually this would only be open for 6 weeks. That August, not a lot of research assistants and research students around, because what we want to do is to submit our own apps with the clinical trials in which they have been involved. So not only do we submit our apps, we also submitted all the evidence. And we did this 5.5 weeks into this period, and then 3 days later, the site actually closed down. It would have been helpful if the Department of Health had told us that there was going to be a finite period during which this was going to happen. But even in those 6 weeks, there were nearly 500 suggestions posted, 7,000 votes, 900 comments, etc. And of course, you would not be surprised to hear, if you've been here all day, that a large number of the apps were to do with the management of chronic diseases, sometimes called long-term conditions. And this is what keeps Andrew Lansley and every health minister in the developed world, and now, as we've heard, the developing world as well, awake at night, which is the way that healthcare spend outpaces GDP growth. If you look at the last 20 years, last 40 years, last 50 years, the trend is very clear. It's about 2% points for OECD, and it's worse in the States. It's about 2.5%. That is not sustainable, of course, as we've heard already, and chronic disease management accounts for 80% of this growth. I'm sure you'll know what chronic diseases are. It's not a niche problem. 15 million people or so in the UK, more than half the GP appointments, 2/3 of outpatient appointments, and nearly 3/4 of inpatient bed days. And as I'm sure you know, diabetes consumes, or its complications, 1/10 of the NHS budget, up somewhere between 9 and 10 billion now. These are the 2008 figures. And yet we know there's a lot of evidence saying that the way to reduce these GP appointments, these outpatient appointments, these unplanned hospital admissions, is self-management programs. But we've never been able to scale these up properly. Could new technology help? Well, if you go to the iTunes store, if you've got an iPhone, I'm personally a believer in Android for a reason, and I know that Andy shares the same reason. It's much easier to develop apps for the Android. But if you go to the iTunes store, you'll find between 2,000 and 3,000 healthcare and wellness apps. So if you've got diabetes, you might look at the app to try and manage your diet. This is from Sanofi Aventis. And you've got about 3, I've just taken 3, there's probably about 25 apps to track your blood glucose. However, looking at the blogs of people that use this sort of technology, only 1% of them are still using it 1 month after downloading it. Now, why would that be? Okay, it's not the cost, because it's either free to download or 99 cents, but people stop using them very quickly. Why? Well, I'd like to advance a couple of reasons, and then I'm sure there are others. You record this data, it doesn't go anywhere, doesn't really do anything for you. It's not really have any involvement with any healthcare professional, your diabetes nurse, your GP, or anyone else. So we have been thinking about this in Oxford for the last 7 or 8 years, and have been developing some self-management apps, and we have a number of principles that we use on each one of them. First of all, it's very important, if you put in some data, that you should get some feedback. It doesn't have to be real time, it helps if it can be, but really this is a two-way tool, so you expect that if you transmit some data, you'll receive something back. The other thing is, it must be integrated within clinical pathway. This has really hit home recently in telehealth, is that there's no point having one of these and having something completely outside the normal clinical pathway for diabetes or COPD. Somewhere the pathway's got to accommodate the technology. And of course, as we've heard, to gain acceptance with the medical professional, the apps must be supported by clinical trial evidence. So that's what we've been doing in this particular sphere in Oxford for the last 8 years or so. I won't take you through this. If anybody's interested, I can point you to the papers. But because we work with clinicians every day, we have to do clinical trials of these in order to have credibility with the healthcare professionals. And so we've developed these in the context of closing the loop and being able to do this within a clinical trial. So the individual who, in this case, because diabetes app uses a blood sugar or blood glucose meter, gets immediate feedback on how they're doing in their diabetes management. So you get the real-time feedback in this case, and there's a healthcare professional in the loop. But there's absolutely no point in increasing the workload of the healthcare professional. In this particular trial, the healthcare professionals were spending 10 minutes a month with each of the participants in the trial. And so we did this trial, which has been published in Diabetes Care. It was an RCT, so there was a control and intervention group. And what you get is the feedback and the support from the healthcare professional means that the number of readings, the compliance, if you will, from start to finish, remains the same in the intervention group. Whereas in the control group, it gradually tails away. That's just human behavior. So unless you have the right technology and the support, your usage of it will fall away. If you can provide the feedback and support, in this case, not more than 10 minutes from a diabetes nurse, then the compliance continues right through, in this case, the 36th week of the trial. I could show you many results, but I'll only show you one, that when we started drawn at random from control intervention, we had 10% of our intervention group was well controlled, 20% of the control was well controlled. At the end of the trial, that had gone from 20 to 25%, so hardly any difference. But in the intervention group, went from 10% to 50%. From 1 in 10 to 1 in 2 of our diabetes young adults had become well controlled as a result of the use of this diabetes app. I'm always told, yes, but that's all right, that's in young adults, they're between 18 and 30. Can you do anything for the elderly population which really needs this type of technology much more than young kids? Well, the answer is yes. What you have to do is to adapt the technology to suit the population. So we have another very big trial, which is in the tens of thousands of patients now in Oxford, which is the Oxford Vascular Study. And the extraordinary thing as an engineer, when you look what they do in stroke management, the average stroke patient spends 2 to 3 weeks in hospital after their stroke, having medical scans, CT scans, sometimes MRI, consultants working with them, physiotherapists for rehabilitation. The cost is somewhere between £5,000 and £10,000. Then they send them home with one blood pressure measurement in the outpatient clinic, which costs £5. So they've spent thousands of pounds, and then the biggest risk factor to have another stroke is elevated blood pressure. How do they set the antihypertensive medication? On one measurement in the outpatient clinic at a random time in the day. As an engineer, Nyquist sampling theorem, etc., this just doesn't make sense. So we went to talk to clinicians and say, how about giving them some very simple technology built around Bluetooth and cell phones so that they can monitor themselves daily, and you can see what their blood pressure really is when they go home and adjust their therapy if needs be. First thing to say is that more than 90% of our patients were compliant, very compliant. And look, mean age is 70, a third of them 80 or above. And they all continue for at least a month, sometimes 2 months, sometimes 3 months, because that's how long it takes to get the therapy right. But frighteningly, and one of the things that we want to talk to NICE about is how you move from this to a national introduction of this. 2/3 of the patients had changes in their blood pressure lowering medication. So in other words, for 2/3 of the patients, they had the wrong dose of treatment when they left hospital, and this is the biggest risk factor to have the major stroke that's going to kill you. And so if you put them on the right medication, clear patient outcome, systolic decreases 148 to 127, and diastolic decreases by 9 millimeters of mercury. Very simple use of technology, very clear patient outcomes, very clearly adapted to the population in their 70s and 80s. So those are the 3 points I want to make, illustrated by 2 of our trials in diabetes and hypertension. There's one more in the last 5 minutes. These were targeted interventions. When you go home after a stroke, you will have your antihypertensive medication set within 1 month, or then they'll add another medication will be 2 months, and sometimes they go to a third one, that'll be 3 months. But it's targeted, you know how long is it going to take place, compliance very high, in the upper 90s. Likewise, in our diabetes trials, we were trying to teach the young adult people with diabetes how to adjust their insulin dosage before meals, etc. So again, very targeted intervention. The big problem with long-term conditions, you've got them for life. So if you're going to monitor, you're going to be monitoring for life. A lot of people don't like to monitor because it's simply reminds them they've got this condition for the rest of their lives. So somebody mentioned, when you design this system, this technology, how about spending time with patients? Well, if you spend time with patients, you find they actually hate sticking things on themselves. They don't like it. There's a small sector of the population that doesn't mind. The average elderly person doesn't like putting things on themselves. So can we be clever as engineers and invent some methods that means you don't have to stick anything on you and you can still find out how they're doing? So what we've developed in Oxford is what we like to call inverted commas, and it's inverted commas because we don't want to infringe copyright or trademark laws, health Skype. So when one of these elderly patients with COPD is Skyping their grandchildren or their carer, and a lot more of this is going to happen in the NHS, online doctors coming in, Lloyd's Pharmacy have just introduced a service, simply by measuring the light reflected from the webcam, we can work out how well they're doing physiologically. So the amplitude of the light reflected will be modulated by the blood volume changes associated with the pulse rate, but also at a low frequency, the respiratory rate. And by doing this 2 wavelengths, and the webcam has got 3 wavelengths, red, green, blue, we can work out the oxygen saturation. So we've got the 3 key vital signs for COPD patients: pulse rate, respiratory rate, and SpO2, and they don't have to do anything. Every time they log on to the computer, to Skype or whatever, they are being monitored, and we can follow trends. And of course, because we're in Oxford, we're having to do a clinical trial. We're doing this, it might be slightly surprising, in the Oxford Kidney Unit, which is where I'm meant to be in a couple of hours' time, to present this with the clinical research fellow. Because what happens for patients on dialysis, they're hugely unstable. So their pulse rate, their breathing rate, their SpO2s vary considerably during dialysis. We double monitor them, and here we have the data, which I hope at some stage NICE will accept to validate this technology. And just to give you one final slide, and I've changed the bottom, this is funded by EPSRC and the Wellcome Trust. This is simply, over 5 minutes, the pixel intensity coming back from the patient's forehead. Can't see anything in there. Clever signal processing going from here to there, and that's what sort of things that we do as engineers. In black, you have the camera estimation of heart rate between 64 and 82 beats per minute. And in red and blue, this is from the double monitoring from a finger probe. You can see it follows the changes in heart rate very accurately during this 5-minute period. So, to finish, my final slide to conclude. I thought I would go on to the Department of Health website yesterday, because this presentation, I have to confess, was written yesterday, in fact quite late last night. And what was very nice to see on the Department of Health website, when talking about smartphones and so on, big announcement, the NHS Direct app has now been downloaded 1 million times. Now, whatever you think of NHS Direct, I think that's a fantastic achievement. This is, if you're not sure, it could be you've got medical questions, the main questions, if you hurt yourself, sexual health problems, all sorts of things. There are about 38 frequently asked questions that you can get from downloading this app. And it's been downloaded 1 million times. So this is really happening. The final point I want to make, that great stuff, the NHS Direct app, this is simply receiving data. What I've tried to argue, for compliance, for improved patient outcomes, you need to close the loop. You need to receive information, to use modern words, to nudge your behavior in the right direction. So it's not just the act of sending data, it's the act of receiving information back that will introduce the change in behavior that will give you a better outcome. So, one final recommendation, I thought I'd get away with this, and I know Vodafone are in the audience. When we started doing this about 7 or 8 years ago, it used to cost about £1 a month to transmit the healthcare data. Unfortunately, the operators very quickly discovered that the people who use data services with one of these is to surf the web whilst they're on the train or waiting for a meeting, etc. So now the kind of data bundle that allows you to do this is of the order of £20, £30. Now, to send your blood sugar readings or your peak flows or your pulse oximetry data, that just doesn't make sense. We have been trying for a while, without success so far, but to get mobile operators to offer a healthcare data bundle. I think £5 a month is overpriced. I think it should be £2 or £3 a month for the amount of data that it actually costs. And then marrying that with another idea which is floating about in the NHS now, which is personal health budgets, you would actually be given that money, you as the person with the long-term condition, with a chronic disease, to spend, provided you used it to send data, receive information, and it'd be very easy to check whether people are using it to do this properly, because of course we can see what's happening to the data, and we can, your GP, your diabetes nurse can log on to a website and see your blood sugars, etc. So I think working together with the Vodafone, the Oranges, the O2s of this country, and the new idea of personal health budgets, we would have a fantastic way of nudging the behaviour of people with chronic diseases in the right direction using this very innovative technology. Thank you very much.